Hi, my name is Douglas Forman. I'm a plastic surgeon, and today what we're going to be discussing is care of the postoperative plastic surgery patient. And I'll leave plenty of time at the end for questions. As I'm going along, if you have a burning question, please feel free to ask it, because this is on the informal side. It's really to be informative. So essentially, what we're going to talk about today are the different types of cases that you'll see in the postoperative phase for plastic surgery. We're going to just go over just general patient care information. Then we're going to go over specific things that may be particular to that type of procedure. And as I said at the end, we'll go through some questions and answers. So essentially, there are going to be two main categories of patients that you'll see. And I think this has been a really great thing that Sibley has now done. And because what we're doing is we're really trying to combine that all of the so-called plastic surgery patients, whether they fall under aesthetic or they fall under reconstruction, are really going to end up on the same floor. There's a lot of overlap. And I think when it comes to the nursing care, that's such an important part of getting the patient through this initial phase of their hospital experience and getting them home in a safe manner. And I think it's important, again, as I said, to have everybody on the same floor. So essentially the types of cases you'll see facial plastic surgery cases. Elsewhere, meaning in other ambulatory centers, you may never, these patients typically will go home. A lot of plastic surgery is now done on an ambulatory basis, so those patients you'll never see. The types of things that you'll be seeing that are aesthetic, you'll see patients that are having multiple procedures done that take longer than 6 hours in the operating room, patients who have other medical problems that need care that beyond what their family can offer. Some people who may not have the support systems at home and they want to spend one night in the hospital because they'll feel a little bit safer than as opposed to having a nurse come to their home or a friend that would not be as supportive as the nursing team. You're also going to see a lot of body contouring procedures, and there's certain particulars about that, especially about patient positioning, making sure we prevent blood clots, things of that nature, because those patients are going to be less apt to move than other patients. Excuse me a second. So with all of that, then you're going to see the reconstructive patients. You're not seeing a lot of microsurgery patients here, but you are seeing some. My understanding is they come to the ICU. Am I correct with that? Are your free flaps for the breast reconstruction? Okay. At some point, that may transition to the floor. At another hospital, we actually did transition that to the floor already, because again, the whole team was involved with everything. It's better if they go to the same nursing team for their continuity of care, and then they go home right from the floor. So I don't know if they're discharged right from the unit here, or they go to a floor as a day. Okay, so again, if we can get to the level, especially if the free flaps become that common, that we're getting them right to the floor, and then they go home from the floor, again, better for continuity care, less other problems. The other aspect is you'll see trauma patients. This is not a trauma hospital, but you may see some lower extremity injury, things like that, that they got a plastic surgeon involved. You may see complicated hand cases, or a hand case that needs to spend the evening. And the last thing is you may see skin grafts as well as other flaps that we mentioned. So going to the aesthetic portion or the cosmetic portion, what you'll see here, a lot of the facelifts, because these patients, again, may want to spend the night. They're having multiple procedures. It's not uncommon that somebody will essentially do their eyes, a facelift at the same time, maybe a little bit of a body contouring procedure. And this way they have one recovery period. That's why people combine things. And they don't want to tell everybody that they're having something done. So this way, if they get it all done at once, they tell people they went away for a month and they come back looking refreshed, and that's always a common thing. Personally, I tell patients to get their hair colored, change their glasses, change something else about themselves, so when people see them, they'll say, oh, something's different, I'm not sure what it is, and then they'll jump on their hair or their glasses. So facelifts essentially will remove or tighten the extra skin that you have here, but it is removing it. The scars will go around the ear, behind the ear, and into the scalp area. Typically, all you're going to see is this, because they're wrapped in head dressings. There's a reason why we have our head dressing. It's a little bit for compression. A lot of us will use drains, and we'll talk about the importance of drains with the facelift patient. But the main thing is, we don't want them moving around a lot. If they have a big, bulky dressing, they're going to be less apt to move around a lot and create bleeding. Bleeding in a facelift that becomes something such as hematoma can be life-threatening because it can compromise airway. But it also is a surgical emergency that we have to take them back to the OR that night. And that's one of the things that the nurses will pick up if a patient is spending the night. And we'll go a little bit more into detail on that. The other thing about the bulky dressing is it prevents them from putting their head down like this, because you're raising up all the skin, you're putting it under some tension under here, and when they bend their head down, they're cutting off the blood supply to some of the skin. So they can end up with maybe a line of ecchymosis, or even having some other damage to the skin. So the bulky dressing prevents them from doing this. I didn't have to put a slide on it, but positioning of a facelift patient is very important. I do have the head up elevated, but while I'm on it now, one of the things is it's important not to put a pillow behind the head, because if you put a pillow behind their head, it does the same thing. So we tell them to buy a big wedge when they're at home, those big triangular pillows that go from here all the way down to the lower back, and it's a gentle elevation. That's what they can do at home. Here in the hospital, we have the luxury of having beds that can go to 60 degrees, but when you do put a pillow behind their head, you put it, instead of transversely, you put it longitudinally, so it's covering the back and everything, so it's a gentle elevation, and it's not just doing this. It elevates everything at once. So again, preventing the neck. So that's just one little point that I did forget to put in the slide. Brow lift essentially is raising the eyebrows back up. An incision you again may not see. There may be some more drainage at the suture line. Some of the suture lines will go across the entire scalp. Other ones will just be little incisions when we do it endoscopically or through a camera. Blepharoplasty or eyelids, you'll see upper and lower eyelids. There will be a lot of swelling around the eyelids, and we'll go into that a little bit later. Rhinoplasty essentially is a nose job, as people refer to it. You may see that in combination with other things. It's unusual that that would be admitted on its own. Other things you'll see are abdominoplasties, commonly known as tummy tucks. Also, you'll see a lot of breast surgery. Breast surgery comes in essentially three forms for cosmetic purposes. There's breast augmentation, breast mastopexy, which is essentially a lift, and then breast reduction. Of these three, if you saw anything on its own, it may be a breast reduction in a larger patient. But otherwise, pretty much those are going to be done ambulatory unless they're combined with other procedures. You will see breast augmentation, lift, or reduction as a contralateral procedure often with a breast reconstruction. Because one of the laws passed in 1998 is a rule for symmetry. So if a woman is having a mastectomy and a reconstruction, often for symmetry we'll do something on the other side. So that will fall more under your reconstructive patients. Body lift procedures essentially are abdominoplasties that keep extending all the way around. Sometimes we'll just do the back half, and we call that a posterior lower body lift. And the whole purpose of that is to elevate the skin here, tighten the skin on the outer thighs, the buttock area, as well as to pull down and loose skin. Really, that's going to be in the massive weight loss patients, and but that is something that does typically require one night in the hospital. Same with thigh lifts. Thigh lifts are quite uncomfortable. We're taking this extra redundant skin in the lower thigh area, and we're pulling it all the way up to the groin. Typically, it's sutured right to the pubic bone, and you can imagine that is uncomfortable. So, just for pain control, I personally like to keep them in the hospital one night, but if they've been through other procedures, I may do it ambulatory, but usually it's one night. Liposuction usually is a combination to complement other procedures, but when you do see liposuction patients, you will see drainage. I don't know if any of you are familiar, but liposuction essentially is done in a couple of stages. We put fluid into the tissues. The fluid is called tumescent fluid, and that distends the area that we're operating on, so we can remove fat and layers and get a nice result. It also has lidocaine in it to provide for some analgesia in the area. Most importantly, it has epinephrine in it. Epinephrine constricts blood vessels, you get less bleeding, you get less bruising, quicker recovery. So a lot of that fluid, though, will drain out any way it can. It'll drain out through the liposuction holes, it'll drain out through the drains, and around the drains more importantly. So if there's leakage around the drains, and we'll talk about that in a little bit, you can just reinforce it because that fluid is just going to keep coming out. And that's important to know what the patient had done. Reconstructive, as I said, it's going to be mainly breast reconstruction. You have expanders or implant reconstructions. You have latissimus dorsi reconstructions. That's your largest muscle in your back. We keep this island of skin attached to it. We use the muscle to carry the skin over to the front of the breast to help supplement skin that may be deficient when the mastectomy was performed. Tram flaps, you're not seeing as much anymore because of other procedures, better expander reconstructions, as well as more free flaps, which are called deep flaps. Tram stands for transverse, rectus abdominis, myocutaneous, which is muscle and skin, flap. Deep flap is deep, inferior epigastric perforator flap. That means they take one blood vessel, they dissect that out, they take the skin and fat from here, but they're leaving the muscles completely intact. That one blood vessel, then they suture, they take out a segment of rib, they suture it to one of your internal mammary vessels, or they suture it to vessels in your axillary region. So those, the deep flaps, as I said, are probably coming here for now. They may make it to the regular floor before discharge, or eventually maybe they'll go directly to the floor. Facial fractures you'll see coming in through the ER. Again, that's more of a reconstructive procedure. It's going to be similar care to the facial patient from cosmetic. Decubitus ulcers and other flaps and skin grafts. There will be other doctors that will be admitting those here. Personally, I don't do a lot of those here, but other doctors do, and that may be part of your lecture series. So essentially, let's go over some just general care items. Plastic surgeons are very particular about a lot of things, from the time we see the patient in the office, in the OR, and definitely on the floor. We all have our routines, and every surgeon that I know thinks their routine is the ultimate correct way to do something, even though there's several different ways to do something, we all know that. But everybody is particular about things. But there's some generalizations. Because these patients are having combined procedures, the first thing to do is just understand what they had done. If you don't know what the procedure means because it's written in a form that you may not know, just ask somebody else, or we can actually make a cheat sheet, and if that's something that's requested, I'm happy to do that. But that's why on a lot of these procedures I'm putting the common name as well as the medical name. Sequential compression devices, SCDs, are really important. They have to be on during the whole case, they have to be on during the recovery room phase, and they have to be donned during the floor phase, except when they're walking, because blood clots are the main thing that we want to prevent, especially when we're tightening the abdomen, we're tightening the muscles as well. It causes compression on the inferior vena cava, decreases flow from the lower extremities. So there's a reason why these patients get blood clots. Incentive spirometers, most doctors will have it, again, because these patients have been asleep for 6 hours. You get basal atelectasis, it's in the lungs. You need to re-expand the lungs, very important. A lot of us will use PCA pumps, just because it's a little bit better, a little bit less nausea in the first 12 to 24 hours after surgery. That's a personal thing. Other things, they may have Foley catheters, most will have drains, and then again, position is going to be important. We'll go into some of that. So, a lot of it is getting the patient out of bed. And you're going to find patients that don't want to move at all. Most of them don't want to move. And it's really important that you don't have to go to the extent of Nurse Ratched, but you really have to be vigilant about saying this is what we this is what we need to do in the next 12 hours during my shift. This is what's expected of you as a patient, and I'm not going to let up until we really get it done. A lot of them, we're going to get out of bed the same night. If there's a morning surgery, that's for sure. If not, definitely first thing in the morning. That's why the Venadynes are very important while they're in bed. You want to advance their diet as best you can, but along that, you can also provide antiemetics. Usually they can have several ones ordered. Be careful with giving them too much Phenergan. Personally, I lowered my Phenergan dose all the way down to 6.25 milligrams IV, just because we find the 12.5 makes them too sleepy, too lethargic. So careful with Phenergan. It's going to be difficult for you to mobilize them if they get too much Phenergan. Typically, they will not have any labs unless there's a reason that they thought there was a lot of blood loss in the OR. And that's even for my reconstructive patients. The hospital I do my reconstructions in, I really rarely order labs, because it's not going to change anything. A lot of docs in other specialties may order labs. They're in a hospital patient, they feel they have to order daily labs. The way I was trained is order labs if it's going to change what you're doing. If somebody comes back with a hematocrit of 30, I'm not going to really transfuse them. And I know that maybe they started at 36 before the surgery. But if they're tachycardic, if they're hypotensive, and there's reasons to get a lab, because I need that information, then we'll order that lab. Last thing is, as best you can, you want to teach anybody that's in the room things, because the patient's only there for a brief amount of time, and it's easier sometimes to show somebody who's not getting any narcotics. So dressings. Essentially, and this was brought up in a previous question, dressings that are put on the operating room really should stay in place. If they're falling apart, that's a reason to actually contact the surgeon, or you can reinforce it. But for the most part, you're really just going to reinforce the dressing as needed. Expect that there is going to be leakage around drain sites, and there's also going to be leakage from previous liposuction sites, as I mentioned. with the liposuction sites, it's gonna look like a lot of blood. If you all know the trick, you take a little bit of blood, drop it in the toilet, it looks like there's a lot of blood in the toilet. It's the same thing. It's diluted, but it looks like a lot. It'll look like a Hawaiian punch. But believe me, it'll soak through ABD pads over and over again. But if you think it's frank blood, obviously that's a reason to call somebody, because that's where hematomas are found, especially in combination with tummy tucks. Drains. Drains are a really big aspect, not only for the nursing staff, but also for the patients. The nursing staff, it really is great if we can teach them how to take care of their drains. So the first thing is emptying them properly. And along with that, anytime you're touching a drain, you want to instruct the patient or family member about hand washing. Sometimes we get these funky infections coming back, gram negatives. Well, gram negatives are really only coming from the perineum. They're not coming from other areas. And we realize patients aren't washing their hands as they should at home. So that's just the basic thing to show them. But emptying the drains, measuring the drains. All patients should go home with the little measuring cups, urine cups, whatever it is. If they have 4 drains, send them home with at least 2 cups. If they have 2 drains, send them home with at least 2 cups, because then they can do right and left, then they can write it down, especially if they're living alone. You don't have to send them home with 4 cups, but anything that makes it easy for them, I would recommend. Also, the drains really need to be secured well. They shouldn't be dangling. And these are things to show patients. We use safety pins a lot in our practice just to make sure it stays secured. Milking the drains. Did somebody bring a drain? I asked somebody to bring one today. Great. This is the #1 reason why a drain will leak around the exit site and not into the bulb. This is just the bulb. I need the drain. If somebody can get a drain. I think somebody go over to the OR, please. So we'll go back to that, because milking a drain is very important. I recommend that it's milked every time it's emptied, because that way you don't know if your colleague did it last shift or this shift. The patients say, I'm not sure. You empty your drain 8 hours, milk it. You're not going to pull a drain out. It's very difficult to pull a drain out. I'm sure it's been done, but they're all typically all sewn in. So we'll get to that. And as I said, with family members, you want to teach drain care. So we're going to keep moving. We'll go back to drains. Foley catheters. Foley catheters are really there so much for my purpose to monitor fluid as opposed for patient comfort. Now, if the case ends 5, 6 o'clock at night, and had 8 hours of surgery, I may leave that catheter in, because the last thing I want them to do is to be in retention at midnight. Then all of you are trying to get them frog-legged in the bed, trying to see with a flashlight, having your colleagues come in, the patient's in pain, and it's not a good scene. My attitude is leave those in overnight. But if we're doing a case in the morning, we're done at noon, I may take that catheter out, because my attitude is that patient's going to be out of bed by 4 or 5 o'clock anyway, and then you're not going to have the same type of deal with retention to such a great degree. When catheters come out, again, this is where you have to be tough with patients. Get them out early in the morning, and we'll talk about early discharge in a second. But the longer that catheter stays in, the longer we have to wait for them to urinate spontaneously before they can go home. Get it out 4 or 5 in the morning, that's okay. Make it easier for the next shift that's coming on that's going to get overwhelmed at 7 o'clock with a lot of things. At least that patient's packaged. The only thing that has to be is maybe get them out of bed. Personally, I don't like any bedpans. To get on and off a bedpan, you're using much more of your abdominal muscle sometimes than even getting out of bed with assistance. The other thing about bedpans is it's giving in to the patient about not getting out of bed. They don't think they can get out of bed. Everything hurts so much. And some patients would stay in bed for 3 and 4 days. That's why you have to get them up, you get them to a bathroom, and it's a process, but it's very important. Also, personally, I like that all urine is measured with a hat in the toilet. I call it the hat. I don't know, what is the official name for that thing?
I don't know.
Okay, good, because you could do this with it? Okay, great. I'm sure the parties it's been done. So I think it's very important, because especially after the catheter comes out, some patients will complain, I still feel full and not. I had a patient last week that was in urinary retention after a bilateral breast reconstruction. She was voiding, but we did the bladder scan. She kept having 500-600 cc's, so we put a Foley catheter in, kept her 1 more night because it was more for the medical reason of the retention, and then sent her home the next day and she did fine. But if you're measuring the urine, you're going to get a good sense there's 500-600 being emptied each time. The patient can go home. Lovenox is it's a new thing that a lot of plastic surgeons adopted. We adopted it later because we have a lot of operative sites and we worry about bleeding. But I think Lovenox has been a real great medication that we've been very comfortable with now. Now with Lovenox, one of the first things is, it may not be ordered. We've all gotten calls from the pharmacy at 12 and 1 o'clock in the morning, 12 at night, 1 o'clock in the morning, and this is something I should probably talk to the pharmacy about. They'll say, Lovenox wasn't ordered. Well, there was a reason why. So there is a box that you can check. It says, reason why no Lovenox, no anticoagulants, is because the patient's ambulatory, and that should be sufficient. But you'll also see doses that you may not normally see. In orthopedic patients, if I'm correct, is it 30 BID or 40 BID? What do they get?
Weight-based.
Either one. Plastics will typically only get 30 or 40 daily. They typically will not get BID dosing, and it's usually based on body weight. We've just found that it's a little less likely to have postoperative bleeding. I'm also more comfortable with Lovenox. I can't speak for all my colleagues because I have drains in place. If somebody's on Lovenox 3 and 4 days and the drains are still heavy, meaning bloody, they may not be more than 30 cc's a shift per drain, but they're still bloody after 4 days, I'll stop the Lovenox as long as they're walking well. Patients who have had bariatric surgery previously and now coming in for body contouring, almost all of them have had Lovenox when they had their gastric bypass, gastric sleeve, flap bands, plus minus. So patients are familiar with it. A very important aspect of Lovenox, if I can, yes, perfect. If I can get the bowl too, sure. It's very important, and if somebody has an alcohol wipe, I know you're all so prepared, I'm gonna be fine with them right away, right? It's like asking for a Valium and movie there.
Yeah.
Another good movie. So with everything, back to Lovenox. I have to write the order now because you never know who's going to be taking care of the patient. If an operative site is your typical area that you're going to give Lovenox, think about it, it's not going to get absorbed as well. So if we're having an abdominoplasty, we're all trained to grab the stomach and show them it's easy for the patient to use the thighs. If they've had liposuction in the outer and inner thighs, use the anterior thigh. If they've had circumferential liposuction in a tummy tuck, deltoid. So there's other places that you can give, not in muscle obviously, Lovenox is more superficial. So there's other places, just don't give it an operative site. And the reason is, I'm not sure about the resorption, because all of these areas have been undermined. They may have too much fluid in it, and it may just sit there and it's not having its thing, having its effect. But Lovenox has really been a wonderful thing for patient care. You can help me. Check it out with that. Ah, you caught you, huh? So, and we'll keep moving along. We only have, what time is it? Okay, cool. I'll stay later for questions. Okay. So essentially, let's tie this off so pull the suction. You can take it out of the bag, please. Okay. So typically, a drain is going to be sewn in. This needed the adapter. This is a very small one. I don't think this will work. So anyway, if you could pull that. So that's the patient. So typically what I tell patients, and I show them every single time I empty a drain, is if they're right-handed, stabilize it with the left hand so you're not pulling on that drain stitch. Theoretically, yes, it can pull out. Drain stitch is going to hurt in most instances, so they're not going to, but the family members are going to be very nervous with this. So expect all of that. And so are the patients. Some patients get vasovagal just talking about their drain. And then I'll show you the trick with the alcohol pad. That makes it easier for patients. Typically, obviously I've washed my hands, I have gloves on. And I pinch it close to the patient, and I pinch it completely closed. So now it's off. And then I slide with my other hand, and I let go simultaneously. And you'll notice it creates a vacuum. And the next time you have a patient, make sure you do it. If you're not sure how to do it, ask somebody else who knows how to do it well. We call this either stripping or milking the drain. And again, pinching close to the patient, stripping, and letting go simultaneously. And sometimes when you're done, it'll look totally flat. Why? Because this bulb is on suction at the other end, so until fluid starts flowing in it, it has a negative pressure, and it's just going to look flat until fluid starts flowing in it. Clots will accumulate in here. You do not have to get them out. You're going to probably contaminate stuff if you try to squeeze it or other things like that. But you don't want a lot of clots sitting in the line. Now you don't have to go too crazy, but if you see a little segment of a clot in here, and please explain to the patient, this is not blood clots that we worry about that are going to kill you. And because some patients will make that extrapolation. So you can strip it a couple times and milk that one clot down to the bulb, and then it makes it flow a little bit easier. but it's actually one of the more rewarding things that our nurses in our practice will say. A patient comes in with 5 ABD pads or maxi pads here because their site was draining, and then all of a sudden you strip it out, you see that one clot go there, and all this fluid starts to come up and the bowl just fills up. So milking and stripping drains are important. We talked about the low and the fold. Okay. Now, overall, patients will only spend 1 night in the hospital. Why? The longer you're in the hospital, statistics will show increased chance of infection, increased chance for blood clot. So let's get them out. Even for breast reconstructions, bilateral breast reconstructions, you want to get them all out of the hospital. So with everything, I like to say you're going to package them to go. And that's really the night nurse's job, is to get the patient out of bed maybe even before 7 a.m. Because if we can get them out by 9:30, 10 o'clock, they're not going to incur any other hospital charges. But the main thing is, if they're there, if they're not getting out of bed until 8 or 9 o'clock, their Foley didn't come out till 8 or 9 o'clock, they're barely getting their breakfast at them by 9, 9:30, there's no way they're going to leave by 10 o'clock. After 10 a.m., they start getting $100 an hour charges. These are not 24 hours from the time they hit recovery room. This essentially is a clock that will start, even if they get to the floor at 8 or 9 o'clock at night, because their case was a late case, they still have to be out by 10 o'clock in the morning. I tell family members to get there between 8 and 8:30. I tell the patient they have to be gone by 9:30. That gives you a little bit of a cushion. Attendings. Some attendings will forget. Some attendings will just say, oh, I'll round on my way to the office, or I'll just drop by at 10 o'clock. If you haven't seen the attending by 9:15, 9:30, call them, because they may have forgotten, or it's something that you, again, want to get that patient out. So we like to essentially say you're going to package them up ready to go. So this is where, when we had a floor on this side and they had private duty nurses, it was pretty well understood that that patient was ready to go, because that nurse could go home if all the patients are gone. If the patients are lingering to 12 o'clock, that nurse had to put in some extra time, or a float came over from here and nobody was happy. So just keep that all in mind. It is expensive. The first night here is about a little under $1,000. The next day is $1,400. That's the last I had heard. Very rarely does somebody stay that second day for $1,400. They can have several people at home helping them. The other aspect is, as I said earlier, you want to be firm with the patient. Obviously, you want to be caring and teach them, but you really want to get them moving. So, if you have any questions, now I have 2 partners in my practice, Dr. Roger Friedman, Dr. Kathy Wong. Some of them you may know those names. We like to be called directly. And if you have any questions, call. You're not bothering us. You should find out from each of your particular plastic surgeons what their preferences are. I've given my cell number as well as my answering service number to 5 West. Call. I'd rather be informed than not. And to me, if you're not sure about something, call. So, let's go quickly through some things. Elective surgery, essentially the cosmetic patients are all elective surgery. They are all self-pay. Some of them may be more demanding than other patients because they're expecting the Ritz, 4 Seasons. This is not the Ritz nor the 4 Seasons, but it's still something that we're going to have to take care of them in terms of medically, making sure that they're safe, and also teaching them before they go home. But some of them may, let's just say, try your nerves a little bit and just be patient. It's all par for the course. If somebody's being difficult, walk out of the room, count to 10. Especially maybe their family members that are being difficult. Expect all of this. And it happens also with reconstruction patients because there's a lot of emotions flying with that. So I don't want to say it's just the cosmetic patients. As I said, they're going to stay 1 night. They have to be out by 10 a.m. The good part about the cosmetic patients are they're having elective surgery. That means they're generally healthy. Even if they have multiple medical problems, they're well controlled. They really don't have other issues going on. Multiple procedures we talked about. And the family members may or may not be part of their care. A lot of people in DC live alone. That's why they're spending the night here. Their rides may not be reliable. So one of the things you may want to do when you're coming onto a shift at 7 in the morning is to say, who's picking you up at 9:30? Who's coming to you at 9 o'clock? Oh, well, my son's coming after work. Well, that's really not sufficient. We need him here this morning, or him or her here this morning to take you home. These are the things that people will play their game with you, and you want to get them out. And it's to get better for everybody. Facial procedures. Blepharoplasties, as I said, which are the eyelids, brow lifts, face lifts. You really want to elevate the head of the bed 60 degrees. Those are the main things about that. Ice for the eyes. You want to put ice near the eyes. You do it in the gloves are fine, but you want to put something thin between directly with the ice and their skin because you don't want to create frostbite. These are areas that have been undermined. So, but ice around the eyes will really decrease the bruising, and it's important. You can just leave the patient sleeping there, come back an hour later when it's all now liquid, put a new one on. The more ice in the first 24 hours around the eyes, the less bruising they have. The hardest thing are corneal abrasions because it's uncomfortable for the patient. They feel like a grain of sand. I don't know if any of you have had corneal abrasions from contact use or something, but it's really a drag. Essentially, it used to be that we'd patch the eye after we put some ointment in. Nowadays, we just put a little ointment in and ask them not to open their eyes as much or rotate their arm.